So thanks for that question. I think that's a very interesting one and really one to my heart, because I think, and that's not only what I think, but that's also shown, the immune reconstitution, that's the main driver of the outcomes after transplant. And what my lab and others have shown, if you have an, let's say, timely and robust immune reconstitution, you can prevent viral reactivations, non-relapse mortality. And so the main messages I always have is that CD4, and that's what we have found and others, is the main predictor of these outcomes, in particularly non-relapse mortality. So that's the ultimate endpoint. So before that you have the viral reactivations, but also, for instance, getting, let's say, control over graft versus host disease. If you develop graft versus host disease, and that's what we have shown in a big analysis between Memorial Sloan and Princess, let's say, Maxima last year, if you develop graft versus host in the context of adequate immune reconstitution, you are ultimately, let's say, good. So yes, you may have a bumpy time because you have, let's say, developed acute graft versus host disease, but you are able to get control over your acute graft versus host disease. And what we have learned from pharmacokinetic and dynamic analysis is that the clue is into the, let's say, conditioning regimen. So most of these less patients who have an hampered or delayed immune reconstitution have an overexposure of agents that are given in the, let's say, conditioning regimen prior to allotransplant. So examples are ATG, Fludarabine, and we have shown that that an overexposure in pediatrics, in let's say, adults, less population, in a T-replete setting, in a T-cell depletion setting, that overexposure influences this CD4 reconstitution. And we also have shown in a prospective clinical trial, if you individualize the ATG, because we have found in, let's say, population PK analysis, that weight and the absolute lymphocyte count prior to the first infusion of ATG are the main predictors of the clearance of this ATG. So if you can individualize the ATG based on weight as well as on the absolute lymphocyte count, you can get to a better predictable ATG exposure after transplant. And a better predictable ATG exposure after transplant results in a better predictable immune reconstitution. And in a prospective clinical trial, which was recently, let's say, published in, let's say, The Lancet, we have shown that it works, that if you individualize, this was in a pediatric population, if you individualize the ATG dosing, it will result in better immune constitution and subsequently in a lower non-relapse mortality, resulting in a better overall survival. A similar clinical trial we have open at MSK, and this enrolls pediatric and adult patients up to 70 years who will undergo a T-cell depletion BMT. And the preliminary results look very encouraging and align with what we have seen in this Parachute clinical trial, which was recently, let's say, published. So immune reconstitution is really crucial. And with the PKPD analysis we have done with ATG, and I'm now focusing on ATG, but we have shown similar results in Fludarabine, by using these PK models, individualizing the dosing of these agents prior to transplant will result in a better predictable immune reconstitution after, and subsequently in a better survival.